Actually a big topic, so I will try to reduce the amount that I'm going to describe for 10 minutes. So the treatment of lung cancer include different procedures, surgery, chemotherapy, as well as radiation. However, the interventional oncology plays an important role, particularly as being one of the important players in the multidisciplinary tumor board. So what I'm going to describe is the definition of the clinical concept of the local therapy for lung tumors, the new techniques, developments, what we are going to do by ablation technique, and what is the future of combined concept. How to do a proper tumor ablation. This is really a difficult task, which allows the combination between the technology that we have, the experience of the operator, as well as the tumor response and biology. Our target is to use cytoreduction and downstaging of the tumor. So different ablative techniques that are available, including microwave ablation, radiofrequency ablation, laser technique, and we were one of the advanced and the early centers that applied the laser technique in the lung treatment in Frankfurt group, cryotherapy, and irreversible electroporation. Different advantages for the ablation therapy is being a selective damage of the tumor and leaving the rest of the lung free. This is important to spare the healthy lung tissue, and it's an excellent imaging during the procedure. We do the procedure under CT guidance. This is a relatively low cost in comparison to surgery, and the patient gains rapid quality of life and recovery. This is, in this video, you can see the principle of the ablation treatment is to do an coagulative necrosis within the tumor bed and to leave the healthy tissue and within a safety margin to use complete ablation and without leaving any micrometastases surrounding the tumor. So we have different techniques for ablation, including cryotherapy, heating ablation techniques, HIFO. I will avoid talking about the physics. Indications for pulmonary ablation includes the thermal ablation could be applied for different types of lesions, either primary or even metastatic. And the first case reported for ablation was in year 2000s, and afterwards we had an extensive use, and now the number of cases ablated per year is exceeding over 150,000. So it's important to select the case. The intention is either curative in order to induce a long-term survival associated with effective local tumor control, neoadjuvant in combination with other treatments like surgery to convert unoperable cases into operable cases, symptomatic treatment to control pain in cases of metastatic deposits at the chest wall to improve quality of life, and palliative in order to, in cases of inoperability or post-surgical recurrence or failed systemic chemotherapy. The inclusion criteria for ablation therapy: inoperable or irresectable primary lung cancer, or other cases including metastatic diseases, non-candidate patients for surgery due to medical reasons like pulmonary fibrosis or due to limited pulmonary reserve. The number of the lesions is 5 per lung, and lesions size is less than 5 centimeters in axial diameter. Histopathology for the confirmation of malignancy, not to induce ablation for benign lesion. Exclusion criteria include progressive tumor disease or non-controllable primary, or when the lesions exceeding 5 in number or 5 centimeters in axial diameter, or uncontrolled or uncorrectable coagulation profile. The positive factors that in advantage for the ablation treatment is the tumor size. Up to 3 centimeters are adequately controlled, and particularly peripheral regions up to in the outer third of the lung parenchyma. Negative factors are the size, also over 3 centimeters in diameter or adjacent to blood vessels due to the Hing-Sengt effect, and less than 1 centimeter from the trachea or main bronchus, esophagus, or proximality to the diaphragm and heart. Different needle systems are available for the radiofrequency, and to induce the large size we can use multiple electrodes, or to use the cooled end effect. And this is a video that shows how we do the ablation. The procedure is done under CT guidance. We will do adequate marking of the position or surface marker at the site of the access for the lesion, and afterwards we insert the needle under CT guidance to be inserted adequately inside the lesion, and followed by application of the energy to induce eradication and coagulative necrosis of the tumor with safety margin as we described. This is a case of CT-guided images for RF lesion, metastatic colorectal cancer, the posterior segment of the left lower loop. And after ablation, you can see the presence of scarring tissue at the tumor bed, denoting complete success. This is a metastatic deposit of breast cancer who underwent radiofrequency ablation. And you can see that the presence of regression of the size as well as the contrast enhancement pattern post-ablation at the follow-up at 9 months. Another advantage for the ablation technique is the multiplicity of the lesion. This is a case who had 3 different metastases from colorectal cancer, and the ablation therapy could be done for the patient at 3 different regions, and 24 hours post-ablation showed no presence of complications, and this patient was tumor-free for 2 years post-ablation, and in CT we didn't find any local residual or tumor progress. This is another case of bronchogenic cancer, which is proved at the periphery, and this is during the application of the electrode. You can see a large zone of ablation and ground glass opacification surrounding the lesion, and follow-up 18-month post-ablation showing fibrotic deposits, fibrotic changes are scarring at the ablation bed. I still have 3 minutes, so. Response of radiofrequency ablation of pulmonary tumors in a prospective study from an Italian group that showed that, that there is no difference, the effect regarding the histopathology, and the size of the lesion is one of the most important parameters for expecting the outcome. The complications like pneumothorax has an incidence was in 27 patients, which is less than 10% of the population group, and the tumor survival were in up to 95% in the first year for the primary lung cancer, and up to 83% for the cases in metastatic group. This is how we do the laser ablation technique. In laser ablation, we insert an applicator inside, and afterwards we put the the laser optic fiber within the sheath, and afterwards we apply the energy. You can see that the presence of the energy results in evaporation of the tumor bed, and you can see the presence here of like a cavity due to the effect of the heat, and afterwards you can see that there is like a cavity at the tumor bed, denoting complete ablation with a safety margin. Not all cases are successful. Sometimes we have progresses, as you can see, depending on the selection of the case. This is a case in basal lesion, showed adequate ablation, however, in this case, there was progress post-ablation, and we were decided to shift to chemotherapy as a palliative technique. For the microwave, it has a larger advantage over radiofrequency due to the high energy that we can apply. This is a metastatic colorectal cancer, and after doing the ablation, we get a large zone of ablation zone at the tumor bed, and 6 months post-ablation, we see also a telectatic zone, and we did the PET scan, and we showed that there is no activity at the tumor bed, denoting success of this ablation technique. This is a central lesion of metastatic breast cancer, and during the ablation there was a complication like hemorrhage at the tumor bed as well as progress. So it's always to select the cases central lesions are associated more with risk of complications. So the complication that we may experience in ablation technique is the pneumothorax as the most common complication with incidence up to 28%, and pulmonary hemorrhage with incidence, which is the most dangerous complication but happens in 5%. We published the analysis of the risk factors. The risk factors of pneumothorax, one of the most important factors is the COPD and the size of the lesion. Smaller sizes are more liable for complication due to the manipulation that we need during the application, as well as the depth of the lesion. Deeper lesions or basal lesions are associated with higher incidence due to the movement of the diaphragm, which is leads to more shearing effect. As you can see in this example, a basal lesion showed more pneumothorax. Crossing a pulmonary fissure results in the presence of pneumothorax. This increases the incidence over 14 times, so avoid to cross a pulmonary fissure during the access. The hemorrhage associated with different factors like the size. Smaller sizes are also associated with increased risk of bleeding due to the manipulations used during the procedure, as well as deeper lesions associated with more risk of injury of the lung parenchyma, leading to more incidence of hemorrhage. Positioning of the electrode, you can see in this example, the lesion is centered over a pulmonary vessel, so to get access from anterior aspect, you has a higher incidence of traversing pulmonary vessels, leading to more incidence of pulmonary hemorrhage. Basal lesions for the same effect due to movement of the diaphragm leads to more incidence of bleeding. This is an obese patient who had a large access towards the lesion, and it was associated with bleeding. So we need to get access to the smallest factor. This is the last case that I'm going to describe. This is a case of pneumonectomy due to bronchogenic cancer, showed two focal metastases, and we were able to ablate these lesions in 2 different sessions, and the patient was tumor-free in follow-up, and which was a great achievement. So ablation technique is a minimally invasive technique that could be helpful for the treatment of different pulmonary, primary, or metastatic pulmonary diseases. Thank you for your attention.
Thank you, Professor Nour, for